All right, so today's lecture will be on range of motion and flexibility. Um, when you think of what an athletic trainer does, a lot of it is range of motion and increasing flexibility, right? We're doing a hamstring stretch on a patient or a joint mobilization or some other type of manual therapy, right? So some of the objectives today will define flexibility, ID factors that limit flexibility, differentiate active passive range of motion, and some other things here. So when injury occurs, there's almost always associated loss of ability to move. Makes sense. If you sprain your ankle, you're going to have decreased range of motion in your ankle, right? Due to pain, swelling, muscle guarding, or spasm, loss of neuromuscular control, or a combination of these factors. The loss of neuromuscular control is actually a big one for long-term dysfunction, and we'll get there. So restoring normal range of motion is one of the basic primary goals following any injury. The book defines flexibility as the ability to move a joint or series of joints through a full, non-restricted, pain-free range of motion. AROM remembers range of motion. You notice I underlined, bolded, and italicized pain-free because as we age, as I'm getting older, I notice this. I wake up in the morning, my back's stiff, my knee is sore, my ankle's sore. And I don't do much these days. I golf, I ski. I mean, I played baseball for 12, 15 years, but I'm not a competitive athlete anymore, right? So a combination of joint range of motion and flexibility. So joint range of motion, things to take into account with joint ROM is shape of the surface, capsular, I can't say the word, capsular, wow, and ligamentous structures. So remember, every joint has a joint capsule. Think of the joint capsule as a peanut shell, right? The outside of the peanut shell. And then inside the peanut shell is that actual joint. And within the joint is typically some kind of ligamentous structures, right? Muscle flexibility is really the ability of that musculotendinous unit to lengthen. So the muscle and that tendon that attaches to the bone, remember, tendon attaches muscle to bone, ligament attaches bone to bone, right? So if I tear my ACL, that's a ligament that attaches my femur to my tibia. If I tear my biceps tendon, right here, that attaches my long head of the biceps actually to my superior glenoid rim of the labrum. A little different, right? Flexibility involves the ability of the neuromuscular system to allow for efficient movement of a joint through range of motion. Again, it can be one joint or a series of joints. You're going to hear a lot of repetitiveness here, right? I felt like this whole chapter just kept repeating itself. That lack of flexibility can impact the entire kinetic chain. Males will have decreased range of motion compared to females. If you saw me, and we'll do this in lab on campus, if you saw my hamstring range of motion, if I'm lying flat and this is me, I don't want to give you guys the finger. My hamstring range of motion is about 10 degrees. It sucks. So what happens is that lack of flexibility affects my whole entire kinetic chain. You guys will make fun of me when you see me walk. I walk like a duck. My feet turn out like that. Always have. There's a word for that you guys will learn in eval class. So I walk retroverted, right? Because of that, I have some left SI joint, so sacroiliac joint tightness and some pain there. I have forward head posture. We're going to pick on each other, and you'll understand. I'll stop picking on myself because it's really hurting my self-esteem right now. So, but you guys will see somehow how some of your lack of flexibility can actually affect your whole kinetic chain. And it goes back to this neuromuscular system. So if we can reset this, we can kind of help increase flexibility without even stretching somebody. It's creepy. So important flexibility to the patient. So lack of flexibility can create uncoordinated, awkward movement patterns. I think of little kids. Little kids can sometimes be, very awkward. They're probably very, very uncoordinated. Not necessarily due to loss of neuromuscular control, but little kids can be that, right? So lack of flexibility can create these movement patterns due to loss of neuromuscular control. So the evidence between flexibility and improved athletic performance is conflicting and inconclusive. So they're saying if you actually try to keep increasing flexibility, the more flexible you are, it doesn't necessarily improve your athletic performance. But that's not what we always think, right? Research studies actually show it could actually decrease strength, endurance, power, joint position sense, so proprioception, and reaction times. So is this really what we want to put an athlete through prior to competition? So they have decreased strength, endurance, power. They don't know where the body is in space, and their slow reaction times. Probably not. There's no true cause-effect relationship between flexibility and reduction of injury. So what that means is there's no true relationship that if I'm more flexible, I have less injuries. Kind of weird, right? Most people, even sometimes I do this, fall into that thought process of, oh yeah, you're not flexible enough, we need to stretch you and you'll be better. No, that's not always the case. All right, so anatomical factors that limit flexibility, muscles in their tendons, right? Along with the fascial sheaths. Now remember, fascia is like a saran wrap that overlays or on top of the muscle, right? So you can have a fascial kink. So if you look at my nice t-shirt here, you can see it's nice and ironed. Not really, right? So if I have a fascial kink, maybe my fascia goes like this. So now wherever that kink is in the fascia, that's where I'm going to have some dysfunction. Maybe it's on my left side over here, right? And now maybe I'm sitting like this all the time. So what is the combined effect of, or the prolonged effect of me sitting like this? I'm going to have muscle shortening, tightness on that left side, muscle lengthening on my right side. The fascial sheaths will get tighter on my left side. I'll have decreased range of motion. I'll probably have some kind of pain. Now my joints are immobilized for a long period of time. That elasticity is shortened. And maybe that joint, my spine, is actually sitting like this, and maybe I can't rotate one side to another, right? This is actually the most responsible factor for limiting range of motion. So we need to increase elasticity of muscle to increase range of motion. Joints immobilized for a long period of time, or even a short period of time, lose elasticity and shorten, right? So if you're in a sling or a knee immobilized or whatever it might be, you're going to lose some motion. Excessive joint motion or hypermobility, right? Hypomobility would be decreased ability to move, right? Hypermobility would be excessive joint motion. So usually they have slack ligaments, joint capsules. They can hyperextend joints. Like I can't hyperextend my elbow, maybe a tiny little bit, right? But you see excessive joint motion more in females compared to males. Also, dancers. Dancers have crazy excessive joint motion, right? That bony end feel, and hopefully some of you guys are have this, right? Have some hypermobility. I think Dr. Caswell said that she had mentioned that at least one of you is a dancer, so I'm hoping that you have good hypermobility. No pressure though, right? So that bony end feel is like when you hyperextend your elbow and that bam, the bones hit together. You're gonna feel that when you're stretching somebody, right? Fat to a point, right? Adipose tissue, skin maybe, especially after wounds or burns, right? Skin's less pliable and malleable. And then neural tissue tightness. Nerves can become tight. Interesting. Yeah. So, if I can't even do this. This is how you stretch your ulnar nerve. Ulnar nerve goes behind the elbow here, goes down here, feeds your fifth and medial portion of your fourth digit. So to stretch my ulnar nerve, I can't even do it. You would go like this. As soon as I do that, I feel burning here. My right or my left side, I can do that. Right side, I look like an idiot right now, I know, but you guys should do this. We'll hit this again later in the chapter, but that's how you stretch your ulnar nerve. Active and passive range of motion. So active range of motion, you will always see abbreviated AROM. Active range of motion or dynamic flexibility. This is the degree to which a joint can be moved by a muscle contraction, usually through the mid-range of movement. So they're moving it, right? The patient is moving their limb, whatever limb it is, their joint, I should say. It's not necessarily a good indicator of stiffness or looseness of a joint. Why? You can't really feel anything if they're moving it, but why else? So the passive range of motion is static flexibility. This is you moving the joint for that patient. The degree to which a joint can move passively, so you're moving it, to the endpoints of the range of motion. No muscle contraction is needed. It can be moved further in passive range of motion than active, which can be important for more injury prevention stuff. Some partner stretching you can do some passive range of motion with. Goniometer. I actually do not have one here in my office. Yeah, goniometer is literally a protractor with measurement in degrees. So you line it up properly, you should get the same measurement. It should be a E, get, not GT, the same measurement. So if I were doing my, let's do elbow range of motion. You have a fulcrum. The fulcrum goes through the midline of the joint, right? So the elbow is right here. You have a stationary arm that would actually go up my humerus, and then you have a movement arm that goes along my radius. So we start at 0, right? And we go through flexion. And then I move the movement arm in line with the radius, and it tells me what that motion is. Now, biceps is a good one, or elbow flexion is a good one. I don't have huge biceps, right? So if I had big muscle, big biceps, say my biceps came out to here, I'm going to automatically have decreased range of motion because I've nowhere for my elbow to flex anymore because my biceps is in the way, right? But luckily for me, I don't have big biceps, so I have, probably 130, 135 degrees of elbow flexion versus, bodybuilder, big, muscular person, they might only have 100 to 120. That table in your Prentice textbook is good, and that's an eval class necessarily in this textbook, right? Rehab Techniques for Sports Medicine by Prentice out in Chapel Hill and UNC, University of North Carolina. That table's good because it does include normal active ranges of motion, so they're moving it, right, for most of the major body parts. So stretching to improve mobility. Your goal is to improve range of motion at a given articulation or joint by altering the extensibility of the neuromuscular tendinous units, right? So stretching and improving range of motion due to neurophysiological phenomena or mechanism is called the stretch reflex, which we'll get there in a little bit. However, new research indicates changes in the ability to tolerate stretch and or viscoelastic properties of muscle are possible mechanisms. So back, forever now, people have thought that the stretch reflex is how we can improve mobility or improve range of motion, right? But newer research is indicating the ability to tolerate the stretch, the improvement or the viscoelastic properties of muscle are also possible mechanisms. So we have things called mechanoreceptors, right? When stimulated, the mechanoreceptors inform the central nervous system, brain and spinal cord, of what's happening in that specific muscle. We have two different mechanoreceptors that we talk about a lot. Muscle spindles and Golgi tendon organs, or GTOs. Both receptors are sensitive to muscle length, but GTOs are affected by changes in muscle tension. All right, so muscle spindles, more muscle length, they both do muscle length, but GTOs are affected by changes in muscle tension. So, bam, muscles being stretched. GTOs send that sensory impulses to the spinal cord. Initially, the impulses from the muscle spindles, not the GTOs, the spindles inform the central nervous system, right, brain, spinal cord, that the muscle belly, muscle's being stretched. Impulses return to the muscle from the spinal cord, causing the muscle to reflexively contract, thus resisting the stretch. That's the stretch reflex, right? So GTOs, muscle spindles. I put GTOs send sensory impulses to the spinal cord, but it's, both the GTOs and muscle spindles. The muscle spindles inform the central nervous system as well, brain, spinal cord, as well as the GTOs, right? That the muscle's being stretched. The impulses return from that muscle to the muscle from the spinal cord, causing that muscle to reflexively contract. Little resistance, right? Thus resisting the stretch. The GTOs respond to the change in length and tension. So now if we provide more tension, the more GTOs are firing, the more resistance to the stretch we're getting. It's reflexive, right? It's called autogenic inhibition. If we hold stretch for at least 6 seconds, the GTO override the muscle spindles and can cause a relaxation, right? So when that relaxation occurs, it's really that autogenic inhibition phase. It's that good phase that we're actually going to get a lot better stretch. So how long do you hold a stretch for? We'll get there. So 6 seconds, and you'll hear that 6 seconds again during PNF stretching. So collagen enables tissue to resist mechanical forces and deformation to the tissue. Elastin composes highly elastic tissues that help in recovery from deformation. So essentially, the collagen is helping, enable the tissue to resist some of the mechanical forces and deformation. It has different properties here. We have mechanical and physical properties. The mechanical properties: elasticity, viscoelasticity, and plasticity. So elasticity is the capability to recover normal length after elongation. Okay. Viscoelasticity allows for a slow return to normal length and shape after deformation, so after the stretch hits that certain phase. And then that plasticity, and you've heard me use this term a couple times throughout the summer, plasticity allows for permanent change or deformation within the tissues. So if we're stretching a hamstring, we might get this and this, but if we don't hit this plasticity phase, we're not actually allowing for permanent change or deformation within that hamstring muscle to actually increase range of motion. We might hit the elasticity and viscoelasticity properties, right? But we're not hitting that plasticity. Maybe. I say might because most of the time we don't hit that plastic barrier. Physical properties: they have force relaxation. This indicates the decrease in the amount of force needed to maintain a tissue deformation, and you'll have this over time, right? Less force is needed to maintain that tissue deformation. The one I always think is weird is the creep response. I don't know. Ability of a tissue to deform over time while constant load is imposed. So these two kind of go together. These two kind of go together. And plasticity and I can never say this word. Hysteresis. Hysteresis, the amount of relaxation a tissue has undergone during deformation. So these two kind of go together, plasticity and hysteresis. What questions do you guys have on that? You guys haven't actually emailed me many questions yet this summer, which is whatever. I mean, hopefully you guys are understanding it, but I am around, so. Okay, injury. If the mechanical and physical limitations of connective tissue are exceeded, injury occurs. So if we exceed these two things, essentially we go into plasticity at too fast of a speed or velocity, right? Injury occurs. We strain our hamstring, tear our hamstring, grade 1, 2, 3, right? So contractile, non-contractile elements. Determines the muscle's capability of forming and recovering from deformation. That depends on the degree of which the muscle is stretched and velocity of deformation. The greater the velocity of deformation, the greater the chance of exceeding the tissue's ability for viscoelastic and plastic change. So the greater the speed, the greater chance of exceeding the tissue's ability to handle it, and now we have a muscle strain, a tear in the muscle, versus a stretch, right? We see this a lot during eccentric phase of motion. So remember, eccentric is muscle lengthening. It's like hamstrings. Typical hamstring strain, person's running, and right before the heel strikes, so in the last about 10 to 20 degrees before their heel hits the ground, that hamstring is lengthening eccentrically, right? What happens is they feel like they got shot in the back of the hamstring by a sniper. Bam. Grab their hamstring, they go down. That is classic strain. The muscle is lengthening eccentrically. The body can't handle it. It's overloaded. Maybe that muscle is a little bit weaker eccentrically, whatever it might be. It exceeds the plastic and deformation. The velocity exceeds it, and bam, they now have a hamstring strain. I did my master's thesis on hamstring strains at Old Dominion. I believe, if the number's correct off the top of my head, 32% of hamstring strains will reoccur. So essentially 1 out of every 3 people will have another hamstring strain. So stretching and kinetic change, joint hypomobility is lack of mobility, right? Lack of mobility is one of the biggest causes of pain. So if you don't have that mobility, it can cause pain. And that is why we get more pain as we age, because we lose some of that mobility. Faulty posture, I have it, all right? Muscle imbalance, I have that. Or abnormal neuromuscular control, I probably have that, right? So faulty postures, as I said before, I have forward head posture, my shoulders are rounded. Having forward head posture, my anterior neck muscles, a little tighter. Posterior neck muscles, a little weaker, a little elongated. There's not a good balance now, right? Pecs, for me, going to be tight. If I push in here, I'm going to have trigger points, or tender areas, tender points even, right? On my posterior spine, my thoracic spine, I'm going to have some muscle lengthening, right? Muscles can become tight and hypertonic to prevent additional joint translation. So they can become tight and hypertonic to prevent additional movement of that joint. This leads to compensation elsewhere, or neuromuscular dysfunction. So muscle tightness affects normal length tension relationships. Once a muscle becomes tight, it alters normal joint arthrokinematics, right? It can cause abnormal joint stresses, soft tissue dysfunction, more. There's so much more it could cause, right? If I have a tight hamstring muscle, now my pelvis becomes rotated, right? So if this is my pelvis here, all right, my hamstrings are near my thumbs. Actually, I'll do it. My hamstrings are here, and my index fingers. My hamstrings are tight. That's going to cause my pelvis to tip, right? So now my ASISs are up high, my PSISs are down low, my posterior superior iliac spines are low. So now my pelvic girdle is off. So now what happens? I have decreased neuromuscular control. This can alter firing order of different muscles involved, right? So instead of one muscle firing first, it might not fire at all. It might fire last in the order it should. The prime movers of the body become slow to activate, and now my stabilizers may become overactive. So now, just because my hamstrings are tight, my pelvic girdle's rotated a little bit, right? Now I could have SI joint, sacroiliac joint pain. I could have iliotibial band, IT band pain, right? Tightness. I could have glute tightness. So muscle tightness can cause reciprocal inhibition. The increase in muscle spindle activity will cause decreased neural drive to the specific muscle's antagonist. This alters normal movement. So if I have a tight psoas, my gluteus maximus becomes inhibited, and then this chain reaction occurs, like I was talking about with my hamstrings. So if my psoas is tight, glute max becomes inhibited, might not fire properly. So now my glute max is an extensor, right? So now when I walk, my gait is off. And now I can't walk properly. Now my gait's off. Now maybe I don't have a limp or anything like that, but I could develop, pronation or supination at the foot. And now I'm putting abnormal joint stress on my tibia. And now I have a stress fracture because I'm a cross-country runner. And it actually didn't come from my leg. It came from that tight psoas muscle. But how many people actually look at the whole kinetic chain when, they have pain at my tibia or my foot? How many people are looking at that psoas muscles, the cause of their foot pain? Probably not many. In lab in a couple weeks here, my goal is to do some functional movement screen, FMS a little bit, but a lot more of SFMA, selective functional movement assessments. We'll kind of assess each other's movements and try to fix each other a little bit. Okay, muscle temperature and stretching. This goes without saying, right? In order to most effectively stretch a muscle, the intramuscular temperature should be increased prior to stretch. How do we do this with modalities? Think back to moist hot pack, diathermy, ultrasound. How are we going to do that? This causes the Golgi tendon organs to relax through autogenic inhibition. How else can you do this? I almost never use moist hot pack and ultrasound and stuff like that, right? I have them hop on a bike, warm up till they start sweating. I know their core body temperature is now increased, and then I can now stretch them. Why? Increase blood flow to that muscle because the core body temperature is increased. Cold, and according to our book, can also be used. The research out there says cold before stretching with a patient suffering from delayed onset muscle soreness can be actually effective at increasing that increasing the range of motion. A few different stretching techniques that we're going to do in a lab and this summer. Dynamic stretching is repetitive bouncing motions. Static stretching is stretching a muscle to the point of discomfort, then holding it for a period of time. That's the most common one we see. And then we have proprioceptive neuromuscular facilitation, or PNF. You'll almost never hear me call the whole word, right? I always abbreviate this as PNF. Altering contractions and stretches of that muscle. So with dynamic stretching, safety, back in the day, I should say, and even today, some people think it's a controversial way for it to stretch for many years, right? Not so much now, but there's still some people out there, right? Many physical activities require antagonists contracting eccentrically to decelerate the dynamically stretching muscle. Yes, they do. So it's good for dynamic warm-up. So what type of dynamic stretches do you think you can think of for a hamstring? What about for biceps brachii? All right, so biceps in your arm, hamstring. This is dynamic. Remember, it's like a repetitive bouncing motion. Static stretching, most common. Everyone, I feel like at some point has had a static stretch done to them. All right, you stretch, you hold, you repeat. So you take the hamstring, you feel that barrier, you hold, bring it back down, stretch a little further, hold, and repeat. All right. Several studies state between 15 and 30 seconds is the most effective length for holding that static stretch for increasing flexibility. How would you do a static stretch for a hamstring? How about for a biceps? All right. PNF, we have 3 different types of PNF. Wording can get confusing. I hate the wording our book uses. As you can see, I put some YouTube videos in here from a rehab class that I found on YouTube. I think these videos are good. All 3 videos are from the same rehab class. So watch the videos. I'm a visual learner. I need to see this stuff. I can read it off the slide, and it makes no sense to me sometimes, right? So watch the videos. They're going to make more sense than what I'm about to say. Contract, relax is one of the 3 types of PNF that we'll talk about. It moves the body part. You move the body part you move the body part passively into the agonist pattern. The patient pushes isotonically, not isometrically, isotonically, so they move through that range of motion. All right, against the AT, therapist, whatever you want to call yourself, the AT. The patient relaxes. AT moves the body part further in a range of motion. You repeat this 2 to 3 times. This is beneficial when range of motion is limited by muscle tightness. Why? Hint GTOs. With contract, relax, and I think the video actually says this. I'm trying to remember when I watched it yesterday. Whenever I'm having them in a stretch, I'm holding that roughly 6 seconds. A little bit longer, maybe 7 seconds, right? And then when they go through the range of motion, relax. I stretch them back. I should be able to go further. Hold another 6, 7, 8 seconds, back down 2 to 3 times, right? Hold and relax is a little different. This begins with an isometric contraction of the antagonist, the muscle being stretched, against resistance. So with hold and relax, you can actually get that patient in that position. The patient then, with about 10% of their body strength, pushes into your shoulder, hand, whatever it might be. About 6 seconds. Relax. You stretch them further. I usually hold it 6 seconds, and then they push into me for 6 seconds. And then relax, push back further, right? This is considered hold relax, or a muscle energy technique. You'll hear this also called MET, or muscle energy technique. Again, another YouTube video from the same peeps. Slow reversal hold relax. What the hell? Also known as contract relax contraction. Why they keep changing names, who knows? So this is an isotonic contraction of the agonist, which limits range of motion in the agonist pattern, followed by an isometric contraction of the antagonist, the muscle that will be stretched. Patient usually brings their leg as far as they can go. I'm using the hamstring because it's the easiest, right? Leg as far as they can go. You put your hand on their leg, they push into you about 10% of their body strength, about 6 seconds, right? Relax. They make a quad muscle, they push their leg even further. 6 seconds, relax, push the leg even further. Makes sense? This is useful for increasing range of motion when the primary limiting factor is the antagonist muscle group. Another video, right? With hold relax, I didn't say this is appropriate when tension on one side of the body or joint. Comparing these, dynamic, obviously recommended for dynamic activity. You see this the most during warm-ups for activity, right? Potential for causing muscle soreness in sedentary persons. That's why people say it's not good. If you're not an active individual, you have an increased risk of muscle soreness. With static stretching, most widely used, simple, it doesn't require a partner, it's pretty safe. PNF stretching, I actually use PNF when and if I actually do stretch somebody. I feel like I use PNF the most. You know, some of these other things I use because, you know, I have students with me as a preceptor, so I want the students to experience all these different types of stretching and whatnot, so they'll do them. But PNF, I think it's very effective in improving flexibility over an extended period of time. Yeah, the neural structures. You need to be able to differentiate between neural and muscle tightness, and we'll do this more in lab, right? You can actually floss a nerve. Just like you'd floss your teeth, you can like stretch your sciatic nerve. All right, so that page 225 textbook has great photos. Try them, they hurt. I can't do the ulnar nerve one. All right, Google it. So this is the ulnar nerve one, it hurts. In that picture on page 225, they have 2, I believe, upper body ones, and then I think 2 for the sciatic nerve. We'll definitely do these on campus, and I've actually used these quite a bit. I use the sciatic nerve one a lot. Last couple of years, I've had some dancers with some herniations of their L4, L5, and L5S1 discs in their lumbar spine. So I would actually do the sciatic nerve one quite often. Specific stretching exercises for joints. You're actually going to do this with Mars, I believe, during the fall and spring semesters. You do joint by joint stretching later in the program, right? That page 231, table 8.2, and page 231 of the text. It's a resource of how to kind of begin a stretching program. I'm not going in depth into it. In this summer, we'll obviously do a few body parts, just so you guys can get used to stretching people. But Marcy should be going over step-by-step joints. Different alternative stretching techniques that I can never remember the names of. I actually use a few yoga stretches a lot with the dancers, right? Because it's the only way for them, because they're so hyper mobile, so they have excessive movement. It's like the only way I can target some specific muscles, right? Pilates stretching I don't do as much, but yoga I definitely do. What's the one? They're on their knees, butt to heels, arms out like this, and they can go side to side. That's one I do a lot. Literally, never remember the name though. We'll do some of these in lab. Manual therapy for increasing mobility. This is the stuff. This is like my bread and butter. This is my strong point. I will do this during this last week. We'll do this during the last week of the semester in class. I love this stuff. I'm good at it. I'm not trying to toot my own horn, but I like it. I'm good at it. This myofascial release, awesome stuff. I can do myofascial release with pretty much any body part. We'll learn how to do some myofascial, so you guys are at least getting your hands wet and kind of learning some of these manual therapy techniques. Strain, counterstrain, and positional release are very similar techniques. So we'll do some positional release Active release, actually, I don't use as often. I don't like the technique personally as much. I'll show you guys pretty quickly on that one. Instrument-assisted soft tissue mobilization, or IASTM. People mistakenly always say that this is Graston technique. Well, no. Graston is one company that sells the tools and stuff like that. So instrument-assisted. I actually need to check with Dr. Caswell Marcy to see if you guys have instruments. I don't think that George Mason does. My wife has taken courses on instrument assisted. I might be able to borrow her tools. Anywho, massage. I like massage, but we'll do some massage, I think, as well. But definitely we'll do myofascial and positional release. And my very strong point of the Mulligan concept, we might do some Mulligan stuff for increasing mobility too. I can take away headaches like that. Trust me. I do it all the time here. Faculty, staff, random patients, right? They know if they have a headache, they will literally come to my office. I'll take care of their headache. Anywho. Knowing the goals of your patient and why you're stretching them is important. Know the goals first before you stretch. Once you know that, you can pick a specific technique that is best. PNF, dynamic, static, maybe a combination of them. We'll do this a lot more during the lab part of this class. We didn't talk about it much, but maintaining the proper therapist or AT position decreases your risk of injury. AT is one of those professions that, we're on the court, we're on the field, we're in awkward positions, stretching people, doing things. You could actually hurt yourself. Physical therapists are very good at positioning their bodies when working with a patient that they don't injure themselves. ATs, we're not very good at that. So we're going to do a little bit of that in the lab. And there's actually a lot of research out on stretching. If you look in the Journal of Athletic Training and whatnot, there's a ton of research. But there's very minimal research on the true effectiveness of actually stretching a patient to actually increase range of motion and flexibility. Okay, so the rest of this week we are going to do strength and then some proprioception stuff, regaining neuromuscular control. And then a little bit of manual therapy before we get onto campus, in August here. So it's winding down.